You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Joaquin Buitrago, nurse educator at the University of Texas MD Anderson Cancer Center, member of the Houston chapter of ONS and education committee member, to discuss multiple myeloma and the nursing implications of care, specifically the pathophysiology of the disease, treatments, and clinical practical issues to promote the best patient outcomes. The development of today's program was supported by a sponsorship from Janssen Oncology. Joaquin, thank you so much for joining me today.
Well, thank you so much for having me.
So to start us off today, can you provide a foundation for our conversation by explaining what multiple myeloma is?
Well, yes, multiple myeloma is a hematologic malignancy affecting the bone marrow with significant consequences affecting the bones and kidneys. The disease starts in the bone marrow in the developing of the plasma cells. These plasma cells are part of the white blood cells, and its function is to produce natural antibodies that we call immunoglobulins. The importance of immunoglobulins is that they act in the cell-to-cell recognition of pathogens and binding to their cell membranes to assist in the killing of these bacteria, fungus, or viruses. Plasma cells with chromosome aberration creates the tumor activity that occupies a large portion of the bone marrow. That poses a problem because along with the absence of apoptosis, that leaves less space available for other cell development, and the tumor expansion and infiltration is another problem for patients experiencing the disease.
Well, before we get too much further into the disease specifics, let's talk about the etiology. What are the possible risk factors of multiple myeloma development?
Yeah, that has been the focus of attention for many years by researchers. According to the American Cancer Society, the risk factors for developing multiple myeloma varies. But some of them they include is age. As we become older, our immune system weakens, and some of the malignancy may develop undetected. Another theory is having comorbidities and conditions debilitating the immune system. Gender is another potential risk factor, as more males assigned at birth are more likely to develop multiple myeloma than those assigned as females. Race is another risk factor. Although these remain unclear, being of African American ethnicity increases one's risk of developing the disease. Family history is another risk factor. Despite the fact that most cases present without family trait of multiple myeloma, in some cases, having the disease from siblings or other family members might be a trait for patients. And there is some evidence that family history with other hematology malignancies can increase the risk of having the multiple myeloma. Lastly, obesity becomes still another risk factor, as the excess of body weight has been the center of research for many health conditions, including cancers, and this in particular. So there remains uncertainty since not always apply for everyone, but the inflammatory response system is affected by the obesity or excess of body weight. Cells and blood vessel growth is another problem, as these cancer or tumor cells develop their own blood supplies directly to the tumor. Also, the ability to live longer for some of these cells has become another problem for overweight persons. And the excretion of hormones such as insulin and estrogen, which can stimulate the tumor cell growth, is another problem for patients are overweight. And lastly, angiogenesis is affected by the fact of the obesity or excess of body weight.
That's a lot of risk factors that might be risk factors for several other types of diseases as well. So I can see where that might cause people to not even think about or consider that this might be a diagnosis that they would be having. So, what are the pathophysiologic effects of the disease process?
Yes, physiological consequences of the disease. One of them is anemia. As we understand, the plasma cells are occupying most of the space in the bone marrow. Other cells, like the red blood cells, have less space for development. So one of the consequences is anemia. Similarly, the white blood cells have less space for development, and therefore the patients will develop neutropenia. Similarly, the platelets have less space for development, and they will showing up signs of thrombocytopenia. Hypercalcemia is another problem, as the calcium element essential for bone formation is dislodged and going into the circulatory system. So that causes hypercalcemia. And another landmark is the spike on the monoclonal protein, M protein. So that dislodging that M protein into the circulatory system create worsening the kidney function filtration.
Well, how do patients present clinically into the doctor's office or to the ED with this diagnosis?
That is an important question because patients present at different stages, and the experience may vary from one patient to the other. Or some patients, without symptoms, they are diagnosed annual physical examination, or perhaps during unrelated medical visits like regular checkups, or as a consequence of motor vehicle or sports or other accidents where they can detect abnormalities in the blood count. For others that have recurrent symptoms, and we have an acronym called CRAB, C-R-A-B. The C is for calcium or hypercalcemia, that the patients usually experience loss of appetite, nausea and vomiting, perhaps constipation, tiredness, weakness, muscle pain, confusion, and headaches. The R stands for renal insufficiency. This creates a decrease in the urine output, swelling of the lower extremities, shortness of breath, fatigue, confusion, nausea, feeling weakness, and irregular heartbeat. A stands for anemia, and the symptoms include fatigue, shortness of breath, weakness, palpitation, and irregular heartbeats, chest pain, and lightheadedness. The B stands for bone pain or bone fractures. This is often the hallmark symptom, chronic bone pain throughout the body, but in most cases it's localized in the lower back, the long bones, and the skull. The pathological and accidental bone fractures, even compression fracture, lead to diagnosis of osteolytic lesions.
That's a lot. And I could see why patients may think that it's not something as serious. So thanks for explaining that a little bit further. So we definitely know that over the last few years, there have been some major advancements in cancer therapy in many diseases. And I can imagine that with multiple myeloma, that has definitely been the case as well. So can you talk about how the treatment has changed for multiple myeloma?
Now, let's talk about what is the foundations of the treatment for the disease. And that depends on the staging of when the person presents to the physician. The disease is divided into basically 3 stages. And that depends on every stage. It depends on the serum beta-2 microglobulin and the albumin level, as well as the cytogenic that they might find under the pathological report, and the LDH, the liver enzymes affecting the disease. So in stage 1, the serum beta-2 microglobulin must be less than 3.5 milligram per liter. The albumin level is 3.5 or greater, and cytogenic is not a high risk. And the LDH levels is within the normal limits. In stage 2, the levels are between the stage 1 and 3. Now let's talk about the stage 3, the serum beta-2 microglobulin is a 5.5 or greater. Cytogenetics is considered high risk, and the LDH levels are high. Now, as the other consideration for the disease progression, depending on that, this is going to dictate the treatment. For instance, in the smoldering multiple myeloma, which is a predisposition for the disease, In some instances, they are treated with lenalidomide and dexamethasone. Metastasis is another determinant for the treatment. And solitary plasmacytoma, usually treated with radiation therapy alone. But in some other cases, a combination of treatment modalities usually is used in the presence of tumor spread. So for some others with active symptomatic myeloma, chemotherapy and monoclonal antibody, along with immunomodulating agents and corticosteroids, might be the treatment option. Chemotherapy, as we know, it exerts its anti-neoplastic effect by interrupting the cell cycle. The most commonly used chemotherapies are vincristine, cyclophosphamide, topoxide, doxorubicin, bendamustine, and melphalan. Monoclonal antibodies are protein made by the body's immune system that we can use to fight infection. They can create synthetic monoclonal antibodies that are targeting specifically the CD38 or cluster differential 38 protein found in the myeloma cells. As an example of this is daratumumab and isatuximab, which are drugs in this group that can both kill the cancer cells directly and can help the immune system attack the cells. The adverse effects of this is coughing, wheezing, trouble breathing, tightness and throat, runny nose, feeling dizzy, lightheaded, rash, and nausea. And as I mentioned, the corticosteroids, like the dexamethasone and prednisone, are essentials for these treatment options as they reduce the inflammatory response. And in some other cases, in combination with antiemetic, reduce the nausea and the vomiting. The adverse effects of the corticosteroids are hyperglycemia, hypertension, increased appetite, insomnia, GI ulcers, and change in mood in some other cases.
Thank you for that. So with all of those traditional therapies that you just mentioned, let's say, I know that precision medicine is something that has gained momentum over the last few years as well. How is precision medicine used in multiple myeloma treatment?
That is a very important concept, not only for medicine, but for nurses to understand, as we target with precision medicine certain pathways or processes with the hope of interrupting the tumor development. For instance, immunomodulating agents work by interrupting angiogenesis. In this case, what they're trying to do is stopping the creation of blood vessels directly into the tumor cells. Agents that work this way are lenalidomide, pomalidomide, and thalidomide. Now, the adverse effects of these drugs are hypercoagulopathy, neuropathy. They have a teratogenicity effect, fatigue, thrombocytopenia, and severe constipation and drowsiness for some others. Other treatments include protease inhibitors that can stop the complex and enzymes in the cells, trying to breaking down the proteins that are important for controlling cell division. That is important advances for as an anti-tumor, because that is trying to stop the development of the tumor cells at this process. Some of the drugs are bortezomib, carfilzomib, and ixazomib. The adverse effects of these drugs are peripheral neuropathy, nausea and vomiting, feeling tiredness, diarrhea, constipation, fever, decreased appetite, myelosuppression, and reactivation of perhaps some other infections like herpes zoster. Antibody drug conjugates are monoclonal antibodies with cytotoxic substances that can cause or through the process of endocytosis. These are linked to proteins that are expressed in the targeted cells, like the CD38. Drugs like Blenrep or belantamab mafodotin, they are given IV typically every 3 weeks. But the adverse effects of these, the main one is keratopathy, which is an ocular and adverse reaction, fever, nausea, and fatigue. Other drugs are nuclear export inhibitors, drugs that can block the DNA genetics material to make proteins needed to function and stay alive. The adverse effects include thrombocytopenia, neutropenia, diarrhea, weight loss, hyponatremia, and respiratory tract infections.
Joaquin, I know that along with the precision medicine treatments and our standard chemotherapy treatments, that there are also cellular therapies that are available to patients who have a diagnosis with multiple myeloma. Can you talk to us about that a little bit?
Yes, cellular therapy is also an option for patients with recurrent and relapsed disease. For instance, a hematopoietic stem cell transplantation might be an option for some of the patients. The autologous stem cell transplant uses the same patient's own cells after treatment with usually melphalan chemotherapy to try to regrow and restate the bone marrow environment. The side effects from the melphalan includes the severe mucositis, myelosuppression, among other effects. Now, studies have told us that a tandem autologous stem cell transplant works better, meaning that after giving the autologous stem cell in about 6 months, repeating the process with more cells from the same patient, and that has proven to improve response and overall survival rate. The adverse effects of the bone marrow suppression, neutropenia, anemia, and thrombocytopenia. There is a high risk for veno-occlusive disease as the liver is being affected by the chemotherapy. Also, interstitial pneumonia syndrome, where the delicate lining of the lungs is affected by either the chemotherapy and in some other cases, radiation therapy. There is a risk for graft failure, although we don't see this much in the autologous transplant. There is a risk present where the marrow does not recover or does not recover on time. And patients that are high risk are those with marrow fibrosis or viral infections. Fatigue can be one of the most difficult to manage symptoms, and we will encourage energy conservation, exercise, and meditation, among other treatments. The long-term side effects of the stem cell transplantation includes cataracts from total body radiation in some instances, or from long-term and large dose of steroids. Infertility remains an issue for those patients at childbearing age, developing of secondary cancers, and also the psychological sequel. The most common fear is the fear of recurrence, as many of these patients, they already encountered previous treatments. The physical functioning, strengthening, the ability to work and exercise can lead to altered quality of life. And lastly, the financial toxicity, which is the negative impact of the cost associated with all this treatment, is often reported as a burden for patients and family. The interventions from the oncology nurses are crucial to support POSI and provide with organizations and community resources while advocating for patients and families undergoing these treatments. The other type of transplant is allogeneic stem cell transplantation from either siblings or from matched unrelated donors. These are options discussed for treatment with these patients. The myeloablative chemotherapy for allogeneic transplantation, usually done with cyclophosphamide and fludarabine chemotherapies. The care plan for stem cell transplantation, again, should include anticipation of potential graft-versus-host disease and prolonged myelosuppression. Lastly, in the cellular therapy treatments, we have the kinetic antigen receptor T cells or CAR T cells. These are genetically modified T cells from the same patient who are modified in the laboratory and then administered back to the patient with the hope that the T cells are sort of retrained to identify the malignancies and be able to attack the cell. Unfortunately, this is not free of adverse effects. The most commonly or lethal ones are cytokine release syndrome and neurotoxicities. These require intense monitoring and intervention, rendering high level of care in many cases.
There are so many treatments that these patients have available from what you just explained. So what are some of the factors that would make a patient a candidate for the different treatments, and how do those decisions get made?
The challenges for the healthcare providers, physicians, nurses at every level is those patients that are relapsed. They don't react or the outcome is not as planned. So when the aggressive disease continuous and coming back. The physicians may offer any one of these available treatments, depending upon the status of the patient, age, with the hope that will be with a positive outcome.
Okay, well, that's good to know. I think from everything you've been talking about, I can see how this disease, this diagnosis is one that is extremely complicated to understand as well as to identify the best way to treat it for patients, and can see why there's that psychological piece of the stress and strain on patients as well. With all of the treatments that we've just talked about, you have mentioned that there are many toxicities and side effects that go with each one of them. With that, what sort of supportive therapy do patients require?
Yeah, that is important because as we administer and we provide care for patients undergoing these treatments, there are undesired effects either from the treatment or the disease itself. So the supportive treatment include, let me give you an example. As we learn more about the myeloma, we understand that cells can weaken and even break the bones. Bisphosphonates or drugs like pamidronate or Aridia or Someta and Exchiva can help strengthening the bone structure by slowing down the calcium loss. Now, the adverse effects of these drugs is important that we understand because they can produce osteonecrosis of the jaw. And this is a serious complication that can lead to excruciating pain, infection of the jaw and the teeth. Therefore, dental and surgical intervention may precipitate the osteonecrosis. And therefore, our education about dental workup, all of that should be recommended prior of starting any myeloma treatment. Other supportive treatments include blood transfusions. As we know, our multiple myeloma patients will experience anemia and thrombocytopenia. So they might be requiring blood transfusions, platelet transfusions, globally in the form of IVIG replacements, antibiotics for those experiencing recurrent infections, and pain control for the osteolytic bone lesions is a plus since these patients are living in chronic pain, and therefore narcotics and nerve blocking agents are usually recommended. We should be aware, nevertheless, that non-steroids, anti-inflammatory drugs should be avoided to prevent further renal damages. So educating patients about over-the-counter medication is extremely important, and what is approved or not by the medical team due to the potential of the renal or any other system in the body. Right? Some of these medications are non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, so they should stay away from those medications.
Okay. We've talked a lot about the diagnosis, the pathophysiology, how patients present clinically. Now let's talk about the nursing role, what nursing care looks like for patients with multiple myeloma.
Yes, Stephanie. Now that we have a better understanding of the disease, now we can establish pretty much the plan of care for the patient with objective information and anticipation of potential risk factors. And therefore, assessment obviously is the most important action that we must do, and trying to anticipate and develop independent nursing interventions, and obviously documenting our interventions. So the focus should be in the infection control and prevention, injury prevention, and renal preservation. When we talk about assessment, specifically since their ability to fight infection has been compromised, so the vital signs and education about these must be addressed, not only to the patients and family, but to our colleagues and nursing assistants and others that are caring for the patient. The white blood cell levels trending up or down, so we can anticipate the problems that may occur. And in that regard, we must always calculate the absolute neutrophil count. That gives us a better picture of what's going on in the marrow activity. This intervention will direct education towards hygiene, crowd control, pets and baby encounters in terms of vaccination. Some of these vaccines are live vaccines that our patients should not be nearby. Nutrition, self-monitoring, talking about the temperature, either in Celsius, about 38 or 100.4 Fahrenheit, and when to seek medical attention in terms of feeling tired, headaches, feeling cold, shaking, chills, body aches, sore throat, cough, shortness of breath, and skin rashes and petechiae, abdominal pain, swelling, pus-like discharges, burning sensation when voiding or confused, and even going into intimacy issues that might be affected by the fact of the pancytopenia, having that risk of internal microbleeding and infections. Safety is the number one issue for multiple myeloma in terms of anemia and bone injury. The bone injury, we can talk about the thrombocytopenia. We understand the low bone density, so as they are more prone for fractures. And energy conservation, as we understand that the anemia causes low oxygen delivery to the system and organs and every vital organ in the body. And therefore, we can educate about declutter living spaces. And that can be the focus of attention of our plan of care.
A lot of things for the nurse to understand and to watch for when they're caring for these types of patients, that's for sure. What are something about multiple myeloma that's not often discussed, but you wish people knew more about?
The main issue that we need to understand is that at the present time, there is no cure for multiple myeloma. Nevertheless, our patients are living longer with all these treatments, with advances in medicine and nursing care. And with that, they can live long for many years with these treatments. And again, to preserve the bones, renal preservation, and immune integrity. That is the main issue that we can address for these patients.
That's an important thing to know. And that's probably something that, as you spoke about earlier, when we were talking about when patients come in, present clinically, and already they're having issues with the integrity of their bones. And so I can see why that is something that needs to probably be addressed very early and watched and patients educated about very early on. There's a lot to know and understand if you're going to be taking care of patients who have this diagnosis. So what are some resources that you can recommend for nurses?
The first organization that comes to my mind is the Oncology Nursing Society. It's dedicated to the education, evidence-based research and practice, and cancer standards. Now, besides the Oncology Nursing Society, there are more resources that our nurses should be able to access throughout the country. Like, for instance, the International Myeloma Foundation is the first and largest organization focusing on the multiple myeloma disease. They are dedicated to improving quality of life and working towards prevention and cure through research, education, support, and advocacy for this patient population. Also, the American Cancer Society educates the public and healthcare professionals. And also they fund and conduct research for the policy development. The Leukemia Lymphoma Society are dedicated to research, policy development, patient advocacy, and support. Now, there are others that are specifically or they're dedicated in financial support. This is such an important issue for the patients, not only myeloma cancer patients, and they are always willing to help and assist with the financial issues. For instance, the Cancer Care Co-Payment Assistance Foundation, they assist with co-payment for chemotherapy and targeted therapy. Cancer Care Financial Assistance Program, also limited financial assistance for cancer-related costs, such as transportation and childcare. And lastly, the Leukemia Lymphoma Society Co-Pay Assistance Program. They assist with the co-payment for blood cancer treatment, private health insurance premiums, and Medicare. And there are more, depending on the area that we practice. There might be other local chapters and organizations that can assist in supporting our patients.
Well, thank you for that and for everything that you have taught us today and the information that you've been able to give us. Do you have any final comments for us today?
Well, you're welcome, and thank you for having me. If I want to say the key points about this is the nursing plan of care should be susceptible, or having in mind that the patients are susceptible for infection, bone injury, renal insufficiency, and chronic pain. There are survivorship programs that may help improve their quality of life, and we should be developing the plan of care with realistic goals and dignity at every stage of the disease. And lastly, we can translate. The idea is to translate all these medical and biological information into the nursing care plan. As we understand this, we can assess, educate, and present with nursing interventions with the hope of anticipating always every single problem and adverse effect that may come either from the disease or the treatment for the best patient outcome. Thank you so much for having me today.
Thank you, Joaquin, for being with us today and for your expertise in this area.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.